So I don't want to take up any precious time from these incredible speakers that have joined us from around the country and even outside of our country. It's amazing that through the Zoom format, we now have participants from multiple nations and across the country. So I just want to say a special thank you to our amazing speakers and our supporters. Our mothership is UC Berkeley School of Public Health and the California Department of Public Health, the Los Angeles Department of Public Health, Blue Shield of California, the major universities of California, the California chapter of the American College of Cardiology, Stroke Awareness Foundation, Tennis Getter Foundation, Johnson & Johnson, Genentech, Novo Nordisk, Health Trust, Boehringer Ingelheim, Marin, and Amgen all sustain this work, and bless you for doing so. We will have complimentary CME available. Thank you, USC, for providing that. And with that, let's go to the next slide, please. We compete against disease and not each other in this project. Next slide, please. Our basic goals are to ensure that patients have their biometrics in good control. Our larger goal is really to drive toward zero preventable heart attacks, strokes, and diabetic complications, as well as heart failure. Next slide, please. I'd like to introduce our chairman, William J. Balmer. He has recently been selected, and I actually nominated him to be the chairman of the state's California Department of Public Health Cardiovascular Disease Master Plan. So his storied career includes training many of the cardiologists in California. He's been an amazing leader in the Right Care Initiative, and I think you all know him by now. With that, let's go to the next slide, please. And Bill, would you please facilitate the meeting?
Well, thank you very much, everyone, for joining us in the middle of March here in this year. And hopefully things are looking better for some of us who have survived the COVID pandemic. But we still have to look forward to cardiovascular disease, and we still need to find ways of improving our care. And that's why we're here today. So we have an excellent program today, and it relates to revascularization, either PCI or CABG, versus optimal medical therapy. And we're going to have the very individuals who were the primary investigators on those trials talk about that information, as well as the perspective from the federal and economic aspects of it that is there, as well as payer perspectives for that. And I do want to give credit to Bob Kaplan, who actually put together many of the programs that are on today's agenda for that. So we're delighted. We're going to have David Marin speak, John Spertus speak, Stephen Scheingold speak, Bob Plass, and then we'll finish up with Bob Kaplan. And again, our thanks to him for putting together this outstanding program today. Next slide. So we're going to start out by talking or reviewing a little bit about the last 20 years of revascularization in California. Next slide. And this just shows that it's fairly stable, our cardiac procedures in California from basically 2000 up to 2019. I point out, if we look at the column on the far right, the column at the bottom, or the box at the bottom, outlines the CABG patients. You can see that that blue bar has gotten smaller. So we're doing roughly half the CABG cases that we were at the beginning of the century at this point in time. So our volume has dropped in half on that. Yet, if we look above that on the far column on the right in purple, In the purple box are those PCI procedures. PCI procedures being both elective and for acute coronary syndrome. And you can see that the majority of procedures done in the state of California are cardiac procedures, are literally PCIs in this particular case that we see here. So that is a relatively large group or percentage for the state of California. Next slide. This shows the trends over the last 20 years in California. Basically, if we look at the blue arrow there, we see again a reduction in the CABG cases by a factor of about 2 over the last 20 years. The arrow in orange actually represents elective PCIs, those done for someone who does not have acute coronary syndrome, comes in electively. We have 2 options in those patients. They're not having a STEMI or an acute event. So we could treat them with either medicine or with a stent or revascularization with PCI. And you can see since about 2005, there's been a decline in the number of those elective cases that we see there for a variety of reasons. We do know that optimal medical therapy has improved over that period of time. And in general, there's been a decline in the elective cases. That, however, is countered by the purple arrow there. And the purple arrow shows the individuals who come into the hospital with acute coronary syndrome and receive a percutaneous coronary intervention. And you can see there's a steady rise in that is there. And that's based on either the acuity of the disease going up or whether coding has increased that. And we'll talk about during this presentation today. But you can see a significant, gradual, steady climb, increase in the number of PCIs performed for what's called acute coronary syndrome, which is emergent chest pain, NSTEMI, or a patient who comes in with a ST elevated myocardial infarction. Next slide. Now, when we come in for CABG, we're often told, and here's the data for the last 20 years and a trend showing the good news for CABG in the state of California is we've been able to cut the mortality from that procedure roughly in half, from a little over 5% to now about 2.25% for that. And that continues to gradually move perhaps down a little bit that we see. So great news for individuals in California. We've reduced the mortality in half for having coronary artery bypass graft surgery. In addition to that, and I won't show the slide, we're doing more cases where we're doing a vessel replacement instead of vein replacement. And that seems to have a better outcome or 10-year survival in those individuals who get internal mammary artery grafts instead of vein grafts. So improvements have gone along with this as we have publicized this. And since the 90s, this mortality for CABG for each hospital has been publicly available in the state of California. Next slide. So now let's turn to percutaneous coronary interventions, and we're going to look first at in-hospital mortality. I've highlighted in the thicker red line the elective PCI cases in the state of California that have been done. And what you see there is that the actual event rate for these cases in the last 2 years, 22,000 cases were elective. The elective mortality is 0.27%, pretty low, much less than 1% in this case. And below that in the line is the hospitals that I follow, the 30 hospitals that have PCI programs without on-site surgery in the building. And there it's been kept at 0% mortality. So very good for an elective case. And certainly it's not uncommon for an interventionalist to come out, talk to a patient for an elective case and say, it's a very low risk that you're having. In fact, the risk is in the neighborhood of 1 in 400 that you would die during this procedure. The mortality goes up a little bit on the left of that for all PCIs, because this includes the acute coronary syndrome patients coming in with a heart attack. And we might expect that there's a higher mortality when you come in without a hospital arrest or an acute myocardial infarction. That's a little bit of a fire drill to get everything done in time. And these are clearly sicker patients at that time. Next slide. So this shows not the mortality just in the hospital for an elective case and an acute coronary case, but the mortality that occurs out to 30 days for that. And similar to looking at 30-day CABG mortality, we're looking at 30-day mortality for PCIs. And you can see for all comers, it's sitting at about 7%. And for individuals for elective cases, it's a little over 1.5%. So it is higher when we count not just what happens in the hospital, but what happens 30 days after you leave the hospital for that. Next slide. And this, if we move out to 90 days, is also important, I believe, for this. If we're doing an intervention, I'd like to know for the next 3 months, you're not going to have a heart attack, stroke, or death from after this event. If we look at the 90-day major adverse clinical cardiac events, which include stroke, heart attack, and death in California for PCI with acute coronary syndrome, yeah, it's higher, it's 10%. But the good news is it's only 10%. When I started out, having a heart attack or a STEMI had something like a 25% mortality. So it does come down with our PCIs for acute coronary syndrome, shown here. Next slide. If we now switch to without acute coronary syndrome, these would be the more elective cases. And remember, I showed you the mortality for PCI in elective cases statewide was 0.27%. But now let's follow them out of the hospital for 90 days, and let's include stroke and myocardial infarction as well as death. You can see we go up from 0.27% to roughly 7.5% in this situation. And it's outlined what the events are for that: mortality, stroke, and need for emergency CABG is listed there as well, and myocardial infarction. So the event rate does rise following discharge from the hospital after an elective case. And we may want to understand that when we're explaining the true risk to a patient who's undergoing elective PCI in the state of California. Next slide. And this shows that there's a trend in California that we used to do all of our procedures in the hospital on the left in blue. And you can see more and more procedures in California are being done in green, which is in an ambulatory surgery department, often as an outpatient. So we realize today that PCIs, and clearly elective PCIs in the state of California, are often done same day discharge. You go home the same day, and we're moving from hospitals to hospitals without surgery, and now to clinics or centers where there's really no hospital associated with it at that time, based on the relatively low risk of PCI events in these individuals, including elective patients. And CMS has recently, in the last 2 years, said that they will reimburse for PCIs performed at ambulatory surgery centers, not in hospitals. So that reimbursement has really pushed this to centers saying, hey, we don't need a hospital to do and bill for this. And that's made a big difference in the trends across the country as well as in California. Next slide. This shows another trend that we've seen in California, and this is valve replacements or procedures that you can see here. It was fairly stable. It has increased in the bar graphs to the right, owed almost entirely to the pink zone. The pink zone is shown on the bottom. If you look at the pink line going up, that represents one thing in California, and that is transcatheter aortic valve replacements, which for the last 7 years have taken off in the state of California. And whereas surgical procedures and volumes have stayed relatively constant, you can see that transvalvular aortic valve replacement is the hottest valve procedure in California today. And those lines continue to go up as we speak, as we're doing many of the elderly patients now with this almost outpatient procedure where they can go home the same day or the next day for it. Certainly very popular in California. Next slide. So this just summarizes what I've said today. And as I said, if we look at the procedures that are cardiac procedures in California, both surgical as well as interventional with PCI, you can see a fairly large volume for those that we see in California. We're doing well over 60,000 PCIs each year in California for that. And that's staying stable at this time. If we look at the area encircled by the red marker there to the right, instead of talking about cabbage procedure with a mortality expected of 1 to 2%, and instead of looking at PCIs for elective procedures with an estimated mortality of 0.27%, the real cost of having a procedure, an intervention or cardiac surgery in California is closer to about 7.5% for these elective procedures. If we include stroke, and if we include mortality, and we include subsequent myocardial infarction in those cases. So when we're looking at revascularization, we should take into account it's probably a 7 to 10% risk for that that procedure in the state of California. And this should now be balanced with the other option, which for many of these cases is called optimal medical therapy, which our next speaker is going to talk about and contrast with for that. Next slide. So in summary, what I can say is that elective CABG and PCI volumes in California are declining, whilst PCIs for acute coronary syndrome in California are increasing at this time for reasons of either coding or selection of patients or increasing acuity of the patients. Perhaps the real risk of California CABG is not 2.25%, which is the 30-day mortality, but maybe closer to 7.5% perhaps for major adverse clinical cardiac events if we go out to 90 days. And similarly for elective PCI, we probably should tell the patient not just the 0.2% elective in-hospital mortality, we should be concerned with perhaps as high as a 7.5% elective outcomes for major adverse clinical events at 90 days to be truly informative for that patient to make the decision compared to medical options. And both elective PCIs and TAVRs in the state of California are moving towards outpatient procedures, same day discharge, and now we're even talking about ambulatory center procedures where they are not performed in a hospital. So that summarizes what we're doing in California over the last 20 years and the directions we're going at this point in time. So I want to thank you for that. And I could go to the next slide because we're now going to contrast that with optimal medical therapy. And it's my privilege to introduce David Marin, who is the Renberg Professor of Medicine and Chief of the Stanford Prevention Research Center and Director of Prevention Cardiology at Stanford University. And he is a well-trained individual who's spent a lot of time at Stanford, but other places as well. And he's been on the faculty of different places. Primarily, his research is focused on primary and secondary prevention of coronary artery disease, and he is involved in many multi-center trials, including for today, he was the chair of the Optimal Medical Therapy Committee for the VA-funded Courage trial, which we'll hear about today, and is the PI and co-chair of the NHLBI-funded Ischemia trial that we're talking about today, and he'll address as well. So we're delighted to present the individual with the most knowledge about the comparison related to both the Courage trial and the Ischemia trial. It's again our privilege to introduce David Marin, who will be our next speaker. David.
You're muted, David.
I'm unmuted.
There we go. There we go.
Thanks so much for that kind introduction. And I will share my screen and get loaded up there. Don't worry, Hattie, I've got it going now. That was
never worried about David being able to do amazing things. Thanks for being with us. Thanks for taking the time, and we're just thrilled that you're with us.
No, my pleasure, and thanks for the invitation. So what you just heard was a great context for understanding the clinical trials that compare event rates in people who have elective revascularization procedures with people who don't have those revascularization procedures, but both groups getting good medical therapy or so-called optimal medical therapy. My disclosures are that I have funding from NHLBI for the Ischemia trial, and my perspective is that of a preventive cardiologist. And I want to acknowledge that the work that I will present is due to a lot of labor of a lot of people in the investigator group that led the Ischemia trial, investigators at 320 sites in 17 countries, and over 5,000 people who volunteered to participate in these trials. So I'll give a little bit of scientific background, review the designs and the clinical outcomes of the Courage and Ischemia trials, and leave the health status outcomes to my esteemed colleague, John Spertus, who will follow me. So CABG, 1960 was the year of the first CABG done in the world. It was done in the United States in New York. And as I think you all understand, but I'll just say it anyway, veins, primarily taken from the legs, or internal mammary arteries and later radial arteries are used in this procedure as bypasses to go bypass the areas of severe obstruction and hook in distal in the artery to provide good circulation to the heart muscle. And these procedures were done to treat they were elective procedures done to treat stable coronary disease, primarily for the relief of symptoms. A number of trials were done in the 1970s and early 1980s. And these results I'm showing you here are from a meta-analysis by Salim Yusuf, published in 1994. On the x-axis is the extension of life in months. And these are different subgroups showing that there was about a 6-month extension of life on average for people with 3-vessel coronary disease, and about a 1.5 year of extended life in people with left main disease, defined as greater than 50% narrowing of the left main. And interestingly, only about 150 people total were in these trials that had left main disease, but that led to our conventional wisdom and our guidelines that everyone with left main disease should undergo revascularization. The relevance of these findings is unclear today because there was really no medical therapy used in those trials. It was just revascularization with bypass surgery versus no revascularization. In 1977, Andreas Grunzig introduced the stenting. Well, it's really started with balloon angioplasty, which developed into stenting procedures in which a slotted metal tube is inserted into an artery and it's inflated with a balloon and then left in place to improve circulation. And these were done for the treatment of angina, but then, as you know, have been incorporated into the treatment of acute myocardial infarction, leading to an improved survival in people with acute myocardial infarction. And then came the development of so-called optimal medical therapy or guideline-directed medical therapy. There's diet, exercise, smoking cessation, blood pressure control, pharmacologic therapy with aspirin and with statins, and now with several other drugs that have been shown to improve survival in people with coronary disease. And so that set up the context for clinical trials comparing optimal medical therapy with or without revascularization. And these 4 trials are the main trials that have been done in the era of optimal medical therapy. And I'm going to review with you briefly the Courage and Ischemia trials. So John Spertus and I and Bill Bowden, Bob O'Rourke, and others were involved in the design of this trial in the 1990s, and we published our results in 2007. And this was, the Courage trial was a comparison of optimal medical therapy with or without PCI for patients with stable coronary disease. Bypass surgery was not one of the treatment options in this trial. The design was that patients who had some objective evidence of ischemia, primarily with a stress test of some form, were referred to the cath lab, and patients were recruited from the cath lab if they had at least one stenosis or one narrowing of 70% or greater. 2,287 patients were randomized. The primary endpoint was death or myocardial infarction. So that 2-component composite endpoint, and this was the main result. In death or MI, no difference between medical therapy versus PCI. We did a long-term follow-up up to 15 years in patients who were randomized in the trial to see if over time there emerged a benefit from PCI in terms of survival. That was not to be the case. There was no difference in long-term survival in the Courage trial. There was, however, a survival benefit for people who achieved better risk factor control. This figure shows the death rate in patients with 0 to 1 risk factor goal achieved at 1 year versus 2, 3, 4, 5, 6. The more risk factors achieved during the trial, the greater the survival. For every risk factor achieved, there was a 16% reduction in death. So although this was a non-randomized comparison, this is just some people did better at achieving risk factor goals than others. Risk factor control improved survival. PCI did not. In patients with stable coronary disease. Another observation came from Cedars-Sinai, from their nuclear lab. This is over 10,000 patients with no known coronary disease. On the x-axis, you see with nuclear stress test imaging, the percent of the myocardium that had ischemia. In the blue line, you see patients in this registry who were not referred for revascularization, and in the red line, people who were referred for revascularization. And what you see is above approximately 10% ischemia, that people who were referred for revascularization had a lower cardiac death rate than people who were not referred and who had so-called medical therapy, although we don't know what the medical therapy was. So with this evidence, I'm jumping ahead. I should say that in the Ischemia trial, we looked at this comparison of less or more ischemia and outcomes. And for acute coronary syndromes, we did not find that worsening ischemia led to worse outcomes. This is a composite of death or acute coronary syndromes. And there was no gradation of risk according to ischemia. However, on the right-hand side, you can see that as the coronary anatomic severity increased, so did the risk of an event. However, PCI did not reduce that risk. So anatomy predicted outcomes, ischemia did not in the COURAGE trial. So this led to the question that we asked in ischemia, and I have to give credit to my colleague John Spertus for coming up with this idea for the ischemia trial. And that is that in patients who had at least moderate ischemia, above that 10% threshold for people having nuclear stress tests, is there a benefit to adding cardiac catheterization and revascularization? And the only way to find out is to randomize. So we took people with at least moderate ischemia and randomized them to an invasive strategy where they got optimal medical therapy, plus an invasive angiogram and then revascularization. Depending on the anatomy, it was PCI or CABG, versus a conservative strategy of optimal medical therapy alone, and revascularization was saved for people who failed medical therapy. This design addressed several of the limitations seen in COURAGE and Berry 2D and FAME 2, because it included patients who, all of whom had at least moderate ischemia. Previous trials didn't have a threshold for the amount of ischemia required for entry into the trial. It randomized people before getting an angiogram. So the patients and their treating physicians didn't know what the anatomy was, and that avoided the potential bias of withholding people from participation if they had really bad-looking anatomy. And drug-eluting stents were used in the ischemia trial. COURAGE and Berry 2D mostly had bare metal stents. And it was a much larger trial than the previous trials. Stable patients were recruited from stress testing laboratories. And those that had at least moderate ischemia, as interpreted at the local site, underwent a blinded coronary CT angiogram, blinded so that we could avoid that bias of having only patients to avoid the risk of patients with really bad looking anatomy being excluded. Patients didn't have to have a CCTA if they had impaired renal function or if their anatomy had been defined within the last year prior to randomization. Those who had left main disease were excluded, and about 8% of patients with moderate ischemia had left main disease in our enrollment population. 21% were excluded because they had no obstructive disease despite the abnormal stress test, and then they were randomized. The primary endpoint was time to cardiovascular death, MI, or hospitalization for unstable angina, heart failure, or resuscitated cardiac arrest. And then the major secondary endpoints were the two-component composite of cardiovascular death or MI, or angina-related quality of life, which Dr. Spertus will present. So a little bit about the baseline characteristics of the population. Average age 64, 42% had diabetes. They had a normal ejection fraction. We excluded people with an EF less than 35%. 90% had a history of angina. 29% had angina that was of recent onset or had become worse over the previous 3 months. 75% had stress imaging tests, 25% non-imaging, plain old exercise treadmill tests. Over half had what was considered to be severe ischemia, and 45% had 3-vessel coronary artery disease, defined by at least a 50% stenosis. 87% had LAD disease, and 47% had proximal LAD disease. And here is the primary outcome of the ischemia trial. The red line is for the invasive strategy, the blue, the conservative strategy. And what you notice is that there weren't a lot of events, and there was not a big difference between the invasive and conservative strategies. A magnified view shows that early on, there were more events in the invasive strategy, about 2% absolute greater risk of events in the first 6 months, but that later on, there were fewer events in the invasive strategy, about 2% fewer, absolute percent fewer in the invasive strategy. Similar findings were for the outcome of cardiovascular death or MI. And that crossover of the curves is explained by more procedural MIs in the invasive strategy. That was the group that was randomized to undergo procedures. Type 4A refers to an MI that occurs in the performance of a PCI, and a type 5 MI is a CABG-related MI. And so early on, there were procedural MIs in the invasive strategy, and the delta remained constant throughout the duration of the trial. But there were more spontaneous MIs in the conservative strategy throughout the course of the trial. And these curves separated pretty early. The invasive strategy had fewer spontaneous MIs, and this was true for patients who had PCI, as well as patients who underwent CABG, which is consistent. The PCI finding, fewer spontaneous MIs in the group that got PCI, is something that was demonstrated in the FAME-2 trial. So ischemia is not the only one to show this, but it does run counter to what people expected, because when you do a bypass operation, you bypass the majority of the artery that may have vulnerable plaque in the course of the artery until that vein or artery plugs in and bypasses that diseased artery. PCI, unlike CABG, PCI just treats that specific stenosis where the stent is inserted, and yet it was associated with a reduced frequency of spontaneous MI. Cardiovascular death was no different in the ischemia trial between the conservative and invasive strategies, and all-cause death was no different. Now, what about ischemia versus anatomy in the ischemia trial? This set of figures shows patients with severe ischemia, moderate ischemia, and mild ischemia for the endpoint of cardiovascular death or MI. And the cumulative incidence of these events was not significantly different. So again, ischemia severity did not predict risk in the ischemia trial, just as it did not in the COURAGE trial. And ischemia severity was not associated with the risk of dying. There was no difference between severe, moderate, or mild ischemia and the risk of death. Now, that's not what we saw with anatomic severity or the amount of coronary disease. These four figures go from, and these are based on CCTA, coronary CT angiography, anatomic severity, going from one vessel disease to two vessel with 70% or three vessel with 50%, to three vessel with 70% or two vessel with 70% and proximal LAD. And as the anatomic severity increased, the risk of death or MI increased. And as you can see here, the blue again is conservative, the red invasive. There were more events in the conservative strategy, more cardiovascular death or MI events in those that had the worst anatomy, three vessel disease or two vessel disease with proximal LAD. And anatomic severity, again, was associated with a greater risk of death. However, the invasive management with PCI or CABG did not reduce that risk of death. The Ischemia Extend study is an NHLBI-funded extension of follow-up for patients who were randomized in the Ischemia trial. Those who survived to the end of the invasive strategy or the clinical trial phase of the study are being followed up for long-term cardiovascular death and all-cause death. And I am sharing with you some unpublished data that we have with Ischemia Extend. It's not our final result. We've only been following for a couple of years. And so the mean follow-up now is 5 years. And in all participants, there is no separation here of the curves for all-cause mortality between the invasive and conservative strategies. So there is no emergence of a benefit in the invasive group when we look at all participants. And this is for the patients with three vessel disease or two vessel disease with proximal LAD. And here we see no difference between the invasive and conservative strategies. So that's it in a capsule for the clinical outcomes for the Ischemia trial. And now I'm going to turn it over to Dr. John Spertus, who led the health status outcomes for the Ischemia trial. I'm going to stop sharing and try to do justice with a better introduction than that, to say that, first of all, most importantly, John is a great friend and colleague. And again, he's the guy who came up with the core idea for doing the Ischemia trial, for which I am eternally grateful. He's the Lauer, Missouri Endowed Chair and Professor at the University of Missouri, Kansas City, and Director of Outcomes Research at St. Luke's Mid-America Heart Institute. John is an international expert when it comes to evaluating health status, and one of the greatest advocates for recognizing the importance of health status. John developed the Seattle Angina questionnaire and the Kansas City cardiomyopathy questionnaire. He again was the principal investigator for the health status analysis for the Ischemia trial. And the title of his talk is going to be shown on the next slide. And I don't remember exactly the name, so I'm hoping that John can put up his slide and I can say that the name.
Well, I can't thank you enough, David. That's a very, very generous and kind introduction. And working with you on Courage, working with you on Ischemia has been really one of the great personal joys of my life. And I'm privileged to talk about the role of revascularization in optimizing patient symptoms, function, and quality of life. These are my disclosures, and most relevant is that I wrote the Seattle Angina questionnaire, which I'll be talking about a lot in this presentation. And I think it's valuable to step back and think about, when we treat somebody with ischemic heart disease, what are we trying to accomplish? I mean, certainly we're trying to make them live longer by preventing acute coronary syndrome events, heart failure, and death. But when you see a patient in clinic, when you talk to somebody who's considering treatment, they fundamentally want to feel better. They want fewer symptoms, better function, better quality of life. And as David alluded to, when I sort of entered this field, all the attention was on the left side of the screen and not on the right. And that was something I was very interested in. And David gave an excellent sort of view of what the ischemia trial was. It took patients with a lot of ischemia on a stress test, and they could be randomized to go to the cath lab where they get either angioplasty or bypass surgery, whatever was most important, as well as medications, or they could be randomized to medications alone. And then we followed them for the clinical events and for their symptoms and quality of life. And David basically laid out that there just was no difference in clinical events between the two treatment arms. And while people will talk about, spontaneous versus peri-procedural MIs, the primary analysis looking at the 5 adverse components of the left side of my figure of living longer, there was just no statistically significant difference. And what we ultimately got on the clinical analyses was an invasive strategy does not prevent death, heart attacks, or other clinical events. Ischemia does not stratify risk, but anatomy may. And, there's nothing in that thing that really talks about what means a lot to patients, which is their health status, their symptoms, function, and quality of life. And so in the ischemia trial, and again, David was the one who got this into the absolute core infrastructure of the trial. We collected a 7-item questionnaire that patients completed, and it takes 1 to 2 minutes. It's very short, but it explicitly quantifies from patients' perspective their physical limitations due to angina, how often they have angina, how they perceive that to impact their quality of life. Scores go from 0 to 100, with higher scores being better. And it had a lot of good data about its, reliability, responsiveness, association with subsequent clinical events. And we focused primarily on a summary score that integrated all of the ways in which coronary disease manifests itself to patients. And so in the ischemia trial, when they were being randomized, at randomization, we got this quality of life assessment. And then throughout follow-up, we got sequential Seattle Angina questionnaire scores so we can understand how their health status changed over time. And the primary outcome was the SAC summary score, but we also looked at symptom control with angina and quality of life as key secondary outcomes. And the follow-up data was very high. I mean, about 90% of all assessments were collected. And I'm going to just give a summary of the results before talking about their implications by focusing on the short-term recovery, 1 year and 3 years. Now, when you present these data, they're a little bit more nuanced than the population mean average. And so we did, and we decided to find this up front, that if we took the frequency of angina at baseline, and this is one of 2 questions, the other asks about nitroglycerin use, over the past week, how often have you had angina? And a score of 0 means you had it 4 more times per day. And a score of 100 means you had no angina over the past month. And so you can divide this into clinical categories of daily, weekly, monthly, or no angina. And it's important to have, from the patient's perspective, how often they report having chest pain when interpreting these results. So in the in the ischemia trial, about 1/5 of patients had daily or weekly angina. About 45% had monthly angina. About 1/3 had no angina at all at the time of randomization. And so when we looked at the curves over time, looking at the SAC summary score, our primary outcome, what you can see is that the average health status of the entire population, starting within 3 months of randomization, was better in the invasive arm in red than in the conservative arm in blue. And this effect extended out to 4 years. We saw the exact same pattern when looking at symptom control through the angina frequency scale and looking at the quality of life. But, this population level average, I don't think is the right way to try and understand these results. And so this is the estimated benefit of angioplasty or of an invasive management strategy with angioplasty or bypass surgery at 3 months in patients who had daily to weekly angina to begin with. And we estimated about an 8.5-point benefit on this scale. And importantly, this is the probability that the real benefit is somewhere along this range. And there's no evidence, we're completely confident that there is a health status benefit on the SAC summary score in patients who had daily to weekly angina at 3 months. When we looked at patients with monthly angina, it was a little bit smaller mean effect, but it clearly very significant. But in the patients who had no angina to begin with, there was absolutely no benefit of an invasive strategy. And another way to think about it is, well, one of our key goals in treating patients is to eliminate their angina, to make them angina free. And so this shows at 3 months the probability of being angina free if you're treated invasively in red or if you're treated conservatively in blue. And on the x-axis is what their baseline angina frequency scale was. Did they have daily, weekly, monthly, or no angina? And if you have a patient with a score of 50, their likelihood of being angina-free with medical therapy alone at 3 months is about 15%. If, however, they're treated invasively, they have about a 45% chance of being angina-free. They're not going to be cured of it, but they've got almost a 50-50 chance of having no angina at 3 months if treated invasively. That difference is so large that for every patient, for every 3 patients who have a baseline SAC angina frequency score of 50, one of them would be angina-free 3 months later if treated with an invasive strategy, the conservative strategy. And the updated guidelines emphasize the importance of shared medical decision-making, which is very hard to do. But I would argue that a graph like this, giving a baseline SAC score, figuring out what their angina frequency score, and then sharing this individual data with patients puts us in a very good position to really engage the patients. Because if the patient comes to us with a baseline angina frequency score of 100, there is no difference in their chance of being angina-free 3 months later, and the number needed to treat is infinity. And this pattern is seen at 12 or at 36 months. So whatever time point you found relevant, you could do this kind of analysis. So in summary, there's no difference in the primary clinical endpoint of ischemia. There are more procedural, peri-procedural MIs with an invasive strategy. There's lower spontaneous MIs, but overall there was no difference. There was no heterogeneity of treatment effect on the primary endpoint, including by the severity of ischemia or extent of coronary disease. And while ischemia didn't predict prognosis and extent of coronary disease did, neither of them identified subsets that clinically benefited in terms of avoiding clinical events if treated invasively or not. However, there were significant durable improvements in angina control and quality of life with an invasive strategy if and only if patients had angina. And so I think there's no rush to the cath lab. I think you try medicines first because you're not preventing death or other clinical events going to the cath lab right away. If they still have angina, it bothers them, then you can offer angiography and revascularization. In fact, my sort of conception of the entire stable ischemic heart disease guidelines boils down to this. You have a patient with stable coronary disease, you treat them with optimal medical therapy, and the treatments are expanding. Optimal medical therapy is getting better and better. Then you try and figure out, do they have left main disease? Because we excluded those patients from the Ischemia trial. And if they do, you go to the cath lab. If they don't have left main disease, do they have residual symptoms? And if they have symptoms, do they bother them? If they don't have symptoms or the symptoms don't bother them, then you continue with medical therapy. But if they do have symptoms that bother them, then you go to the cath lab and you work with your team to determine what's the best revascularization strategy, given that they have symptoms that bother them. Now, I think we can figure out with coronary CT angiograms, left main disease or not, or even make the diagnosis of stable ischemic heart disease. And I think that we have not used the kinds of formal assessments to assess angina that we've been able to do in ischemia with the Seattle Angina Questionnaire. And you could ask the question, I mean, how should we assess angina? And we actually took, and I thought that Dr. Bomer talked about the rise in ACS patients over time and the decrease in stable angina. And the question is that a real phenomenon, or is that due to physician upcoding? And so we had a 10-center study, and we had access to the physician-reported angina, CCS 0 meaning no angina, 1, 2, 3, or 4 meaning progressively worse angina. And we stratified it by those with stable disease and those with unstable angina. And what you see on the y-axis is the SAC angina frequency score. Remember, 100 means no, the patients reported no angina over the past month. And then on the x-axis, you have class 0, 1, 2, 3, or 4. And what we found is that a third of the patients with stable ischemic heart disease had no angina, or a SAC angina frequency score of 100, which is sort of what we saw in ischemia. But even among the patients with unstable angina, 12% of them reported when asked that they had no angina over the past month on the Seattle Angina Questionnaire. And I think this has just increased over time since there's a more appropriate rating for doing angioplasty in patients who have unstable angina rather than stable angina. And so if we start to assess this, not from the physician's assignment, but from the patient's perspective, I think we will get a much more accurate understanding of their angina. And, a quarter of the patients who reported no angina, their doctor said they had class 1, 2, 3, or 4 Canadian Cardiovascular Society classification. So I don't think, and we've done other work to show this, that this was very important. That physician assignment is very accurate. There's a big discordance. And so when we think about risk stratifying or understanding how best to guide patients in light of the ischemia trial, I don't think it's this high-risk stress test. What I think it is it's the Seattle Angina Questionnaire. And that's going to have a profound impact on the way we understand the appropriateness of angioplasty. So right now, we use the CAT NCBR PCI registry, which is in about 1,500 centers throughout the country. And we classify patients as appropriate, maybe appropriate, or rarely appropriate. And this is really done on the basis of their anatomy, their ischemia, their angina, and the anti-anginal treatment they receive. But in light of ischemia, maybe we should reclassify asymptomatic patients without left main disease as being rarely appropriate. They have a number needed to treat of infinity. I mean, they do endure the upfront risks, but they don't have any benefit in terms of either clinical events or angina relief or quality of life benefit. So what we did is we said, well, what would it look like? We didn't have the SACs on all, the patients, but we did have that flawed physician assigned CCS class 0. And we said, what if we reassign those patients to rarely appropriate? And so we published this as a brief report, but basically what you see here is that the proportion of patients as they're currently mapped in the AUCs are on the left, and on the right would be modifying it and reclassifying the asymptomatic patients as rarely appropriate. And the rate of inappropriate PCI goes from about 3 to 4% to almost 22, 23% by reclassifying those patients. Now, a lot of people think I'm like anti-intervention, and that's simply not true. I think we may be doing exactly the right number of PCI procedures in this country, but I think we're doing them in the wrong patients. And this was a study, and we've replicated this. It's a very interesting analysis where John Beltrami went to 207 primary care practices in Australia. And in each practice, he asked the doctors, for the next 10 or 20 patients with coronary artery disease you treat, give them the Seattle Angiography question, whether they came in for chest pain or whether they came in for a flu shot. And then he categorized it into daily or weekly angina. And then he looked at the percent of patients in each practice who had daily or weekly angina. And this is what he found. And this is an enormous amount of variability. So these are outpatients in primary care clinics. And certainly about 10% of these clinics, the patients had, none of their patients, 0% of their patients had daily or weekly angina. However, there were another 30 practices where over half of their patients had daily or weekly angina. Did they come back? Did they even see a cardiologist in the last year? We don't know. But it highlights that there is a large pool of people who would benefit in terms of their quality of life if after optimal medical therapy, they still had a lot of residual angina. So I'm going to stop here, but I think ischemia clearly demonstrates an invasive strategy does not prevent disease progression, but it does improve symptoms, function, and quality of life if they have angina. And that ischemia, the foundation of the Ischemia trial, does not stratify this benefit, but the angina frequency scale of the Seattle Angina Questionnaire does. If we're going to do shared decision-making with patients so that we can align their treatment with their expectations, preferences, and values, we can right now start to use sort of the SAC scale and the simple diagrams we published in the New England Journal. But the ischemia team is actively working on building models to predict patient outcomes and to incorporate them with focus groups with patients into a shared decision-making tool that will translate the evidence of ischemia for patients with chronic coronary disease to individual patients so we can engage them in selecting what they want. And I think we need to think about a new infrastructure for managing stable ischemic heart disease. Part of it will be implementing this kind of shared decision-making. Part of it might be adding these shared decision-making tools to the stress test or CTA results that we collect. Part of it may be surveying patients' health status in primary care clinics to find those who are suffering from a lot of angina and yet who are not being offered more aggressive medical therapy or an invasive treatment strategy. So I'll stop there, and I'm told Dr. Kaplan's going to introduce the next speaker. So thank you very, very much for the opportunity to present.
Thanks so much, John. It's my honor and pleasure to introduce Steve Scheingold. Steve is going to talk to us a little bit about how we use the best evidence from clinical science to formulate public policy. And Steve is the ideal person to do this. Steve, it comes to us from the Office of the Assistant Secretary for Planning and Evaluation in the U.S. Department of Health and Human Services. And there he directs the Division of Healthcare Financing and Policy. Steve is sort of no stranger to this. He's worked in several different federal agencies, and he currently has responsibility that includes research and analysis of the financial impacts of the COVID-19 pandemic, drug pricing and pharmaceutical markets, and value-based purchasing. I've known Steve for quite a few years now. We worked together on a really interesting large clinical trial, the National Emphysema Treatment Trial, where people were randomly assigned to to surgery or to optimal medical care if they had emphysema. And it was an unusual trial in that the actual money for the trial, although the trial was an NIH trial, it was the funding for it actually came from what was then the Healthcare Financing Administration, later CMS. And Steve was responsible for this piece of it. And it was actually quite an interesting undertaking, which we won't get into today. But suffice it to say that it provided a model for collaboration between these federal agencies, but also for how the funding of research might lead directly into public policy decisions. Before joining the Assistant Secretary's office, Steve had a variety of major senior positions at CMS. He had a brief career at Battelle Institute. And then before that, he was a principal analyst at the Congressional Budget Office. Steve holds a PhD in economics from the Pennsylvania State University, and he's published widely on value-based purchasing, reimbursement systems, cost-effectiveness analysis, and coverage decisions. So it's a pleasure to have Steve with us, and I really look forward to your comments. And thanks for joining us, Steve.
Thank you for that nice introduction, Bob. I'm going to share my screen here. And that was hard to believe, almost 25 or 30 years ago, the National Infrastructure, but it was a great experience in good clinical science and policy, just as Bob said. Let's see if I can share here. All right, everybody see my screen? Can we see this?
Looks good, yes.
Thank you.
Yes.
All right, so we'll do a little change of place here because, you know, a couple of confessions. One, I'm an economist and not a physician, so obviously the talk will be a little bit more on that side of things. The other that I'm about to hit my 15-year anniversary of having a multi-vessel cabbage. I was joking with Hattie on the chat that given the data I saw today, I was hoping I would still make it through this meeting. But I say I absolutely feel great. It was I don't recommend the bypass, but if you need one, it turned out well for me. So let's see if I can advance the slides.
You're not able to. If you haven't made any changes, Jenny could take over and you could just say next and she can forward slides. Would you prefer that? We're not seeing them forward, Steve.
Okay, well, I haven't forwarded yet. Let me try.
There we go. Yes.
There we go. Now you see it?
Yes.
So what I'm going to do is talk a little bit about markets, payments, and incentives. And it's all geared towards when we produce such high quality clinical evidence as we heard about today. What are the enablers, both in terms of economics and other factors, of actually getting that good evidence into practice? I'm going to talk about the implications of the value-based purchasing efforts that are going on in Medicare and in the commercial sector, and what other things we need to do besides having the economic incentives right, and besides having such high quality evidence, what else do we need to do? So, of course, we talked about the Ischemia trial today, and I've heard there's going to be a meeting on the Cardia trial, which unfortunately, because I'm teaching, I'm not able to participate in. But Hattie asked me to look up some numbers on cardiac disease. And as I said before, I would prefer to do a little study using my own data, but with short time, I relied on CDC, who estimated about $219 billion in cardiac care each year. And possibly about half of that, maybe as much as 60% is for surgeries. CDC also estimates an additional 147 billion in lost productivity. So that's not medical care costs, that's lost time from work or shortened lives that could have been productive. They also estimate almost 660,000 deaths from heart disease in 2019. What I'm going to suggest is that the population health management that we're looking forward to under the value-based purchasing incentives should really favor focusing on cost-effective management of these patients, whether we're talking about screening, prevention, or treatment regimens. Last Monday, our physician-focused payment model technical advisory committee had a two-day public meeting on the goal of moving towards total cost of care population-based models by the year 2030. And Mike Chernew, who's the director of MedPAC, the head MedPAC commissioner, reminded us that the medical care items and services are inputs, they're not outputs. The output we look for is health. And there's a lot of flexibility in how we combine these inputs to produce health. A lot of the points I'll make today is that the system of fee-for-service reimbursement that has been common for years and years incentivizes high-cost combinations of inputs. Value-based purchasing should incentivize lower-cost use of inputs, and even use of services that are not currently covered by insurance, because they will further reduce costs and improve quality on their population or capitated payment. So about 14 years ago, I gave a talk at the University of Minnesota. It was a combined US-German conference on medical technology and technology assessment. And I talked about an innovation ecosystem. That is a system that includes all of the actors that are involved in doing research and putting it into practice and making decisions, and what all the incentives lead to. And I use this little diagram of what is it that's the process we think of, from R&D funding to the different kinds of research we do, how that leads to new technologies. And I use the word new technology broadly. It could very well be new uses of existing technologies. It could be new treatment regimens. But it goes through most go through the FDA process in one way or another, very dependent on the coverage and payment decisions that Medicare and other payers make, and then all the decisions that physicians and patients make about putting these technologies into practice. And I think what that leads to is basically a dynamic marketplace of incentives that feeds back onto the R&D funding and the basic research we do and the applied research and what we do in clinical trials. My point was that under a well-insured population where reimbursement is mostly fee-for-service, this whole system leads to the incentives to do research on and innovate technologies that improve health, but tend to increase costs. Now, in the 90s, we got better at technology assessment, evidence-based medicine, comparative effectiveness analysis, and that did change the way we do research. It did mean we were making our coverage and payment decisions and practice decisions with better evidence, but nothing changed the incentives for the innovation of cost increasing technologies. We also weren't very successful in bringing in public values and patient values, as John mentioned. That could be very important. But what I want to stress today is that the value-based purchasing and the alternative payment models that Medicare and other payers are fielding could be the disruptor to this process. That is, it could change these incentives so that our research and our decisions at all levels will be more favorable to cost-effective technologies and treatment regimens, those that either have the same outcomes or even better outcomes, but cost less than the alternatives. So being an economist, I have to say this or I lose my economist license, but in well-functioning markets, it provides great incentives for efficiency because informed consumers shop for the best value. These financial incentives make sellers of goods and services, make it necessary for them to adopt new models, new technologies, all to get better, to have better quality products produced at a lower cost. And if you're not, then you get driven out of the marketplace by competition. Of course, as we all know, it doesn't work that well, the basic market system analysis in healthcare. And Burton Weisbrod, way back in 1991, wrote a seminal paper which really said that insurance coverage with fee-for-service payment is a root cause of poor value in healthcare. Basically, as I said, it incentivizes cost increasing healthcare, and it actually provides disincentives for cost reducing healthcare. Now, that wasn't a new thought, as George Bernard Shaw wrote in 1909 in The Doctor's Dilemma, that any sane nation, having observed you could provide for the supply of bread by giving bakers a pecuniary interest in baking for you, should go on to give a surgeon a pecuniary interest in cutting off your leg, is enough to make one despair of political humanity. I think that he was well ahead of his time. More recently, in a Wall Street Journal article, Paul Ginsberg pointed out a number of other situations in which fee-for-service, that is getting paid for each service, your revenues attached to volume rather than outcomes or quality, doesn't give you incentive to control cost, but even gives you disincentives to not, in the case he was talking about, in implementing care regimens that would prevent unnecessary hospitalizations. In our own work at ASPE, which was published in the New England Journal, we studied what happened to readmissions before and after the actual implementation of the hospital readmission reduction penalty. What we found is after the Affordable Care Act was passed, readmissions for those conditions that were targeted by the penalty did decline significantly compared to readmissions for the non-targeted conditions. But once the penalty actually was implemented in October of 2012, the trajectory flattened. Now, one explanation is maybe we reached sort of a natural rate of readmission, and given the conditions that we were studying, that's about as low as you can go. An alternative economic explanation is that what hospitals found is that the opportunity cost of not having a bed filled by a readmission under fee-for-service reimbursement is actually higher than the penalty for having a readmission. So that was an alternative explanation. So Robert Pearl wrote in Forbes as well about these kind of disincentives. That indeed, unless we change the way the incentives are set up in our reimbursement systems, it's going to be hard to sell cost-effective, cost-reducing technologies or medical care regimens. So in another article in Health Affairs, they looked at why there's a preference for what they call low-value innovation rather than high-value innovation. And they broke it into to 4 categories between the low productivity and the high productivity interventions. And then they looked at all those people that would be in that innovation ecosystem and said, why do you have incentives for this low productivity innovation? And some of these, we've all heard. But even with all of these incentives, the authors go on to, again, talk about the perverse incentives of just getting paid for volume. And then suggested that institutions investing in the low-cost innovation will be well positioned in this rapidly approaching future of value-based care. So with that, I'm going to move on to talk a little bit more about what we mean about value-based care, what it implies for payment systems that are going into effect now and in the future. And that I think it's going to set the stage for high value innovation to change the incentives in that ecosystem. So recently, the CMS Innovation Center, who's responsible for many of the value-based purchasing efforts, many of the alternative payment models that are being fielded, tested, and evaluated now, put out a refresh strategy. They said, we've had 10 years of experience, let's study them and let that be a guide to where we want to go in the next 10 years by 2030. And their goal is to get all Medicare beneficiaries with Part A and B coverage into a relationship with accountability for quality and the total cost of care. So basically, that's either going to mean, as I'll show you in a minute, there could still be some fee-for-service payment, but with financial penalties involved for being costly. They also have a goal for getting most of the Medicaid patients into these type of models. And I'd love this quote from Liz Fowler, who's the director of the Innovation Center, is that we need to find a way to bring everyone along. We can't have fee-for-service remain a comfortable place to stay. So basically what value-based purchasing is a way to incentivize a change in the delivery system to get higher value, person-centered, well-coordinated care. And alternative payment models is the incentivizing factor to get there. But I picked out this one statement from McCullen's paper that these models aim to incentivize providers to keep their patients healthy and to treat those with acute or chronic conditions with cost-effective, evidence-based treatments. So the HC plan, the Healthcare Payment Learning Action Network, which started out of the Innovation Center at CMS, but has moved into more of a public-private collaborative. They have a 4-category way of categorizing payments. From on your left, category 1, the pure fee-for-service payment, and category 2, which is fee-for-service payment with a link to quality. Category 3 being alternative payment models that are still built on fee-for-service architecture, but have financial consequences. And then category 4, that is sort of the goal, I think, of the 2030 vision of Medicare, of population-based payment, basically models where the provider organization or the combined insurer provider organization is responsible for the full range of care for a year and may get a population-based or capitated payment for that care. And they set goals of how much payment in the different sectors of the healthcare field should be in these arrangements, especially in 3B and 4. 3B being the the accountable care organization type organizations responsible for all care with financial consequences, or into these population-based models. And I'll leave this with you, but that's just some of the Medicare payment and innovation center models that fall in these categories. Basically, there's little or no Medicare payment that's still in category 1 with fee-for-service with no link to value. And if you think about the Medicare population of about 62 million beneficiaries, almost half of them now are in a Medicare Advantage plan, meaning they get their care through a private insurer. Medicare pays a capitated rate to that health plan. And so the incentives could be quite different. Of the slightly over half, if you look at the right side of the diagram, of the slightly over half, or about 30 million or 32 million beneficiaries, 13 million are already in accountable care organizations. So Medicare is moving very rapidly towards insurer and delivery models, which have very different financial incentives than pure fee-for-service. A caution, though, Medicare is moving rapidly, not the whole healthcare sector. So these goals that I'm talking about are very ambitious. Most large delivery systems are managing a portfolio now. By some estimates, maybe only 20 to 30% of their revenues are coming from these value-based models, and 80 or 70 or 80% still on a basic fee-for-service basis. So their incentives haven't fully changed yet, but hopefully the trajectory keeps moving in that direction. So I would say a reasonable prediction is that this kind of payment model will continue to move forward in Medicare, in Medicaid, and hopefully in the commercial sector as well. And it will lead to much more attention to population health management, and should open the door, I think, for really taking good evidence on cost-effective treatment, whether that be prevention or treatment itself, much more into this innovation ecosystem and getting it diffused. Now, again, being an economist, I do have to give a warning on predicting future events before I go any further. And I always love what a great baseball player Yogi Berra said, that it's tough to make predictions, especially about the future, and the future ain't what it used to be. And when you grow up in New York, you're either a Yankee fan or a Met fan. Yogi Berra was a great Yankee player, but he managed the Mets to one of their World Series. In 1969, the Mets won their first World Series. From 1970 on, I predicted every year the Mets were going back to the World Series, which means I've been right 4 times in the last 52 years. So, but Lawrence Peter of the Peter Principle said, an economist is an expert who will know tomorrow why the things he predicted yesterday didn't happen today. And finally, I always love the one that God created economists to make meteorologists feel better about their forecasts. So with that warning, I'll say I can see a number of changes, and I'm trying these out on this audience. On Saturday, I'll be giving a talk to an audience that's largely health system managers. And I'll see what feedback. But I think, again, this changes as we move to those category 3 and 4 payment models. It changes the incentive across the board for the way care is provided, whether that be the kind of optimal medical therapy instead of invasive therapy, using palliative care and case management. And as I said before, it reminded me, even though, although I don't have it on the slide, we find that the more you go to capitated payment or payment with downside financial risk, if an organization finds a service isn't typically paid, but still will reduce the cost for them, something like case management, they will engage in it. So the other point I want to make, and this sort of takes me out of my depth of expertise a little bit, is as we get into the dissemination and diffusion of evidence. What I've said up to this point is I think the world of economic incentives is changing to really set the stage for cost-effective practice and its diffusion. But what else do we need? And I look at that at three parts: that to get the strong replicable evidence, then the translation and dissemination methods to get the word out, and then the active diffusion processes at the delivery system level to take in this information and make it, put it into practice. One doesn't guarantee the other. And so as I was doing some reading for this talk, it really occurred to me that we generally have the tools and the resources to do the great kinds of research that you all talked about today. Do we need to pay more attention, though, to translational research and implementation science to understand how we best get this great evidence into practice? So another paper I found from Deering and Cox took an old model and adapted it a little bit, but basically they did a normal distribution of adapters from the real innovators that pick things up right away, all the way to the other tail of the laggards. And then in a different paper, in a roadmap for diffusion, they take these different groups of innovators and look at what do they need? How do you get information to them? How do you provide support to them to get them to adopt these new practices? So again, this is way out of my depth of expertise, but I thought it was interesting to point out in the three stages. The other thing, although again, I'm not an expert in translating clinical evidence, I do have some experience in translating research into policy, for our leadership. It's really critical to tailor results to the various decision-making individuals and entities. The one thing I thought of when I read the New England Journal article is obviously that's your first step. If you get into the New England Journal, you get street cred right away. We all aspire to publish there. But the way that was stated, which is great for the New England Journal audience, may not be the best way for some decision makers. It may be something that started with optimal medical therapy being as good and maybe less costly, would be more eye-catching for those audiences. I recently had a great meeting with another researcher and myself and two of our physician-focused PTAC members. I don't want to say that whole name again. One being a research physician who is very talented, and one being a physician who's actually managing multiple physician practices in a lot of these alternative payment models. And the three of our researchers, we got some preliminary results that using transitional care management codes actually had a significant effect on reducing readmissions. It was preliminary evidence, and we started talking about, well, we haven't tried fixed and random effects yet. We haven't done this with clustering. We haven't done these adjustments to the standard errors. And the physician who was actually managing practices said, guys, this is all great if you want to get published, but when I see results as big and consistent as this, I think I have to act on them. So it's sort of a lesson that you really do have to tailor your results. And and also recognize some of the controversies we see now with the use of our classical statistics about how you use p-values and hypothesis testing and confidence intervals, and especially how you interpret them for decision makers. I love the one diagram that I think John used that had both the confidence intervals and the distributions on the same little figures. That was really helpful. And also recognize there's publication bias, and it's a lot easier to say, I found a new intervention that that improves things and my p-value is less than 0.05, than to say, I got a valuable result because I showed that something didn't happen. My p-value was 0.25, as is the case in the Ischemia trial. So I think those are all things to think about. And then I'll leave you with, at the diffusion end of things, I found that a publication that the Mayo Clinic actually has a very sophisticated model of how it finds new evidence and makes sure it gets into practice through their medical care system. So I'll just leave that reference, because I definitely don't want to start trying to read that diagram. So with that, I'll leave it for any questions, or I guess it's my turn to introduce the next speaker. Which is Dr. Bob Plass, the medical director at Blue Shield of California. What I noticed about this, I'm a lover of Bill Maher's show on Friday nights. So when he introduces people, he always says, "Oh, that's my old position." Well, Bob is the medical director for medical policy and technology assessment. That used to be one of my old roles. So Bob has my sympathy on that. So he has a very important position in terms of coverage and payment policy, which, as you remember from my diagram, has really a critical role to play in the innovation ecosystem. So Bob?
Thank you very much for that kind introduction. Just as to start with, I represent and employed by Blue Shield of California. In California, Blue Cross is separated from Blue Shield, so there's a separate Blue Cross plan, but we are all part of the larger Blue Cross Blue Shield Association that has 34 independent plans. And so I'm going to be speaking about the payer perspective of incorporating scientific evidence into payment policy and payment policy decisions. Next slide. So just a little bit of background about medical policy and how it's created. So all medical policy development and discussions are based on available medical literature. Sometimes we go to expert opinions when there is a lack of medical literature available. We often will get expert opinions in addition to that. Anyway, no financial considerations are allowed during those discussions. It's all based on literature and evidence. And then eventually there's a committee, in my instance, medical policy committee consisting of 10 doctors who vote on the criteria and even whether or not to develop a policy or to archive a policy or retire it when it's felt to no longer be clinically useful. All policies are updated at a minimum of once a year. That includes going out and doing a search for new literature that might be applicable. We often find that there's nothing new for a given policy. And in that instance, oftentimes the policy just continues on as is. We have written standards for evidence appraisal that involve the levels of evidence for evaluating the efficacy of the item of interest, the quality of the evidence, whether or not it's a randomized, double-blind, controlled study, or whether it's just a case report, whether or not it's manufacturer supported, et cetera, all goes into sort of weighing that quality of evidence. And eventually we're looking for sort of the net health benefit. So does the procedure, technology, implant, whatever, improve net health outcomes? And that has a durability aspect to it, so that if something is shown to be safe and effective at 6 months, that may not be the same as at 5 years or 10 years. So there are times when we take that into consideration and just say, it looks promising, but there's not enough proof to say that it's actually going to be better at 5 or 10 years and not result in additional complications or reoperations or whatever. And then we tend to use the PICO format in sort of reporting that information, looking at populations, interventions, comparisons, outcome, and time. And so that's a part of the policy that gets created. And I wanted to point out that in California, there's a law in the Health and Safety Code that basically says that the medical directors and medical decisions made have to be unhindered by fiscal and administrative management. And that's one of the issues sometimes that we come up against relative to cost effectiveness that Dr. Scheingold was talking about, in that if we eliminate talking about finances, that tends to make a lot of people happy because the decisions are made regardless of whether or not there's a financial benefit to the plan. But what it causes problems with is trying to manage care and steer it toward a more cost-effective type of procedure. That becomes challenging. We do have the ability, if 2 treatments are equivalent, then we can apply some cost-effectiveness criteria. But establishing the fact that they are in fact equivalent and one is not better than the other can be challenging. And then the degree of cost effectiveness can be challenging as well. There's a big difference between $50,000 and $50. So there are some challenges there, and our legal team regularly gets nervous when we start talking about cost effectiveness or essentially anything financial relative to our medical policies. And then I also wanted to mention that relative to one of the biggest controversies we bump up against is when we consider something to be investigational or experimental. And what that's meant to mean is that when you look at the medical literature, there just is not a preponderance of literature to make it very clear that something is safe and effective and therefore medically necessary, or that there's just not enough information to prove it one way or the other. And often that comes down to how someone interprets the literature. And that goes back to, again, something Dr. Scheingold was talking about in terms of how long it can take for something that's been initially described in the literature to become sort of more mainstream. You're going to have a difference between early adopters, late adopters, and even arguments about what the conclusions of a study mean and how they should be interpreted in light of the deficiencies of the study. And it's incredibly difficult to design and implement a study without any potential problems in it, as I'm sure some of our previous speakers are well aware from having designed and run such studies. There are always criticisms. And so part of what we have to do then is to look at that and weigh the pluses and minuses of the literature that's available and to weigh those issues that may be present. And typically that's going to be described in the rationale section of our policies that describes sort of the interpretation of the studies. And so overall, what we're looking for is not to approve or deny something, but rather to try to find the appropriate use. And that's kind of the fine line that we're trying to walk. Next slide. So we created medical policies related to elective percutaneous coronary intervention a number of years ago. More recently, we have a policy related to elective invasive coronary angiography. The PCI policy requires appropriate use criteria be followed, and we require that that information be provided to us. Both policies indicate that they are not intended to address either PCI or coronary angiography when ACS is present or certain other high-risk procedures. And as noted earlier, that's becoming a problem for us because we've noticed over time that we're getting more and more requests for elective procedures that have the appropriate criteria, but then what we're also seeing is that we're getting a lot of procedures that are being done with a designation of ACS, and currently we're not evaluating those. We don't review them, which unfortunately then leads to the fact that there's the potential for some gamesmanship and declaring something to be acute coronary syndrome when it really isn't. And so that's one of the considerations we have now as to whether or not we're going to need to do some post-service reviews to look at that issue to try to curb it and provide a more precise diagnosis of what ACS is and when it would be allowed. The elective invasive coronary angiography policy, we're in the process of changing that. As it is right now, we allow the Canadian angina levels of level 1 and 2 to require optimal medical therapy as an initial attempt before they can do elective angiography. And we are changing that now to say, regardless of the level of angina, optimal medical therapy needs to be initiated first, and then those that fail or have persistent frequent angina, as was mentioned by Dr. Spertus, would then be candidates to go on to have angiography. And we also are putting in a new description for what optimal medical therapy is, because we found when we initially put in the policies that we would get requests from doctors to do a procedure, and they would say that the patient was on, reasonable or optimal medical therapy. But when you actually looked at what they were on, it didn't meet the criteria. And so we've had to put in more specific criteria as to what that really means, including tables of medications and that sort of thing, so that we have more clarity around what those requirements are. Next slide. And so this is from our what the revised policies are going to be looking like in the next few weeks. I actually put off publishing these until we had this discussion today, in case I came up with some new ideas and new approaches. And there have been a couple of things that came up that I think are worthwhile incorporating. So we'll be looking at doing that as well. And so again, we defined what optimal medical therapy is. And following this paragraph, there's a table of the various medications and doses of the medications that will make it more objective for our reviewers to look at and say, yes, this looks like optimal medical therapy, or no, it doesn't. You really haven't met the criteria. And it also includes, hopefully lifestyle modifications and agents to treat hypertension, hyperlipidemia, et cetera, will be included in that beyond just the optimal anginal medical therapy. Next slide. So that was just sort of a brief introduction or description of how we go about things relative to creating and maintaining medical policies. And again, I want to emphasize that it is, for the most part, based on medical literature and pretty much nothing else. Every now and then, particularly with new technologies, there's basically no medical literature to go on. We try to resort to sort of nationally known sources like Hayes technology or up-to-date things like that that are kind of not associated with the health plan, that it would be somewhat unbiased in their opinion, and we'll try to use that. But sometimes there's still just a lack of information that's available, in which case we may consider it investigational just because there's a lack of information. So I think rather than handling questions right now, we have a question and answer session coming up, and that's going to be led by our next speaker, Bob Kaplan, who is well qualified to handle that session. He was a co-founder of the Right Care Initiative and the technical expert group, and has had previous stints at National Institute of Health, AHRQ, is currently the research director, Clinical Excellence Research Center at Stanford, has had numerous books and articles published that are the sites cited as references and in a lot of other publications. And so with that, I will say, take it away, Bob.
Great. Thank you, Bob. And thanks to everybody. So we have about a half hour or maybe a little bit more for questions and answers. And I noticed that on the bottom of your screen, there's a raise hand function. Let me see if that works. Yeah. So so I think that would be valuable if people want to raise their hands. And also we have questions and answers in the chat. And so just a few that have come up so far. So maybe I can just kick this off. David, and looks like David and Bill had their hands up. Or David, were you just working with the
No, I took mine down, but I have a question. I was going to suggest that Bill ask his first, but I'm talking, so here I go. So for Dr. Plas, you talked about the requirement for optimal medical therapy for patients with angina, presumably in consideration of undergoing revascularization. What about using a validated instrument to assess patient-reported symptoms, such as the Seattle Angina Questionnaire?
Great question. And as a matter of fact, that's one of the things that I've picked up on from this session that we previously had not considered. We do have a shared decision-making that is a required part of the process, but the Seattle Angina Questionnaire was not part of it. I think that's very worthwhile. So when we change a policy, it's not just a matter of saying, okay, from now on we do it. So what it's going to take on my part is going back and citing some of the references like Dr. Spertus showed in his discussion to show what the validity and value is of that. And then we can add it to the, as part of the shared decision-making process.
It also seems like it would make your adjudication of the appropriateness far simpler, right? I mean, it's very expensive to go back and audit charts and second guess a clinician. And, if you get data from the patient that, they're having a lot of angina, you don't have to screen, you don't, it could ease things a lot, it would seem like to me, by bringing the patient's voice directly into the sort of decision about coverage or the adjudication of appropriateness. And, I mean, the biggest thing about the ischemia study is, why are we even doing stress tests anymore? I mean, those are $2,500 a pop, that you pay a Blue Cross Blue Shield for that. And what are you getting? It doesn't define who benefits more from optimal medical therapy versus not. There are cheaper ways to make a diagnosis of coronary disease, or you already know they have the disease. And, it's not clear to me why we're doing something like that versus a $1 Seattle Angina questionnaire.
Yeah, it makes complete sense. And, another corollary to that is that, and particularly we're looking at providers who are making a diagnosis of acute coronary syndrome so that they don't have to go through the prior auth process. If the patient's having zero angina or very rare angina, pretty hard to figure out how they came up with a diagnosis of acute coronary syndrome. So if we have that from the patient saying, here's how much angina I'm having, it's very valuable information.
Great. So I have next up is Hattie and then Bill.
I guess I just have to say that as a former regulator of the health plans and prepaid medical groups of California, I have a lot of concerns about the need to use quality data, because what you see behind me in these graphs is that when we looked at the publicly available data on control of LDL cholesterol to less than 100, blood pressure 140/90, A1C 8, we saw in these prepaid systems not any attention to those critical biometrics until we started the Right Care Initiative back when I was with the state, to drive, to try to get to 80% of patients in good control for those three critical metrics. And you see that once Dr. Kaplan got us a grant from the NIH to implement in one community, within 2 years, we reduced women's acute myocardial infarctions, hospitalizations, or our work was associated with reducing those by more than 20% quite quickly through those simple, controlling those simple metrics. So in something like what we've had presented today, which is far more complex and critically important, I just want to particularly say to Steve Scheingold, as we drive national policy toward quote unquote value-based care designs, we should really be looking at what are the big killers and get real careful about making sure we're watching that quality, like Chairman Balmer does so closely on our event rates. So with that, I'll just say, by using outcomes data, which is what Parag Agnihotri, our first co-chair of our Capital Region group, has suggested, we should be holding accountability toward actual event rates, not just those intermediate biometrics that we have. So I think we just have to be awfully careful about assuming that by having care be prepaid, that's going to be the best for patients. And a more sophisticated model might be a blend of those two models, and we can talk about that later. Anyway, I don't think the answers are simple, and I don't think anyone on this collaborative session believes they're simple. And I worry about a federal policy that might not do enough with clinical quality data to actually protect patients. So just want to put out that cautionary note.
Yeah, I think it's a great point, Hattie. And we're not where we're going to be in terms of what the financial incentives will be in these eventual value-based. We still got a long way to go. There's still a lot of fee-for-service incentives out there. Delivery systems are trying to manage, like I said, with 20 or 30% of their payment coming from these more incentivized models, and the majority of payment from fee for service. But it's going to be a careful balance, and I think we not just at the federal level, but the state level, and at the Blue Cross Blue Shield level, when we implement these models, we shift not only the financial risk, but some of what I, for a better term, would call administrative risk to the delivery system or the insurance delivery system. So, Bob made a great point about the difficulties of not only deciding whether to cover something, but getting the appropriate use criteria into the coverage decision. I remember that very well. But as we go to these more capitated or population-based systems, I think it'll be easier for Medicare and Blue Cross Blue Shield to just say, you know what, this is generally covered, but now the delivery system has the obligation and the financial incentive to use it most appropriately. So maybe my job and Bob's get a little easier on that score. But as you say, what do we do about creating the evidence and making sure it's available to use under those incentives? And what is the right evidence and measures? Each alternative.
I have to say one thing, Steve, that should make all of our blood curdle just a little bit. And I want you to remember it when you go back to your regulatory role in reimbursement. And that is a hospital CEO of a major health system in California said behind closed doors to me and one other person, if we did all that preventive stuff that you're asking us to do in the Right Care Initiative, we couldn't keep our doors open because we wouldn't have enough heads in beds. And that's not fiction, and it's not very long ago.
And I think that's consistent with everything that I said today. Even the readmission data I showed you, heads to beds, even outweighed the penalty you get from having too many readmissions. But I think those incentives, it can change drastically.
And I wanted to point out a couple things. One is that we have an entire division of our company that's looking at innovation and different ways of not only delivering care, but how to pay for it and that sort of thing. We have the same sorts of incentives or desires that I think most of you folks have expressed. One item that I want to point out that is, I think a continued issue that's going to need some attention is what is the role of the individual patient in their own healthcare, and at what point are they held accountable? Because that's one of the problems that I think most providers understand, is that if you have a patient who's been coached and counseled and provided medications, and they don't stop smoking, they don't lose weight, they don't take their medications, it's problematic to hold the physician accountable for those behaviors. And so I think that's something that, again, it's a problem I don't have an answer for, but I do think it's something that's going to need to be addressed. So it is definitely a team effort, and that includes some regulatory oversight as well that sometimes gets in the way of really trying to do the right thing.
I want to get on to Bill's question. I can't resist asking this one little question to Steve and Bob. So one of the big issues is that I think that there's a lot of thoughtful policy that's coming from CMS and from ASPE and other places in government. On the other hand, smart people find good ways to get around the rules. And it's just, one example I was thinking of is Rick Kroenig and Don Berwick have each published separate pieces in the last couple months about what's happening in Medicare Advantage. And that what seems to be happening is that that you can engage in procedures that result in upcoding, and upcoding turns out to be costing CMS an enormous amount of money. So how do we confront things like that?
I'll take a first stab at it. It's incredibly challenging. One of the issues is that in order to look at the potential for upcoding, you have to have some sort of a reasonable standard that you can adhere to, that you can say, this is what standard coding should look like, this is what upcoding looks like. And I'll give you an example of something that we're struggling with in Blue Shield. We have some hospitals that have 90 to 100% level 5 complex visits for the emergency department. So they essentially, 90% of the patients that come into their ER, they code as a level 5. Now, common sense says that's upcoding. There's no way that somebody comes in with an earache or a UTI is a level 5 patient. But the problem is there are no true national standards to use to identify facility level coding as opposed to professional. For professional, there are standards, but for facilities, there aren't. And so that becomes a huge problem in terms of how we can actually mitigate that and try to define it. And then the other problem is that depending on what you're talking about, if it's an issue like this for, doing a cardiac cath, there's probably enough value there, economic value, to do a medical review. But for a lot of things, there isn't. So if you're ordering a CBC or a vitamin D level or something like that, a thyroid panel, it may cost us more to do the medical review and appeals and everything that goes along with it than it does to just pay for the test. And so that's another issue that sometimes gets in our way, is just, the pure economics of it.
Great. Steve, do you want to weigh in on this?
Yeah, and of course, Rick Kroenig is a former ASPE person, so we still talk to him about this issue. It's a significant one. Maybe a little different than what we're talking about today, but it has to do with the risk adjustment of the capitated rates for the Medicare Advantage plans. You can find ways to code a patient that raises their risk score. There's not necessarily anything wrong with that. It may appropriately reflect the patient, but it does cause payments to be higher than we originally established in the program. We do adjust 5.9% for this upcoding every year, but it's not quite enough. So it's what happens in, as Bob said, people are smart out there. Policy lags and politics sometimes interferes. And what that means is, yes, we're paying them maybe more than we should. And that gets to Hattie's point, that they don't have all the incentives yet to do all the right things.
Great.
Yeah, and I wanted to point out that to what Stephen just said, probably a number of you are aware that Kaiser is under scrutiny right now for that very issue of systematically going about trying to upcode. And there's an argument about whether it's upcoding or correct coding, but they're under scrutiny for that very thing to try to get their levels of reimbursement increased. And I also wanted to point out that, issues like we're trying to address with our PCI and invasive coronary angiography policies are to direct more toward sort of right care, as opposed to, we're not trying to deny those cases, as was previously mentioned, that we're not saying we're not anti-CAP, we just want it to be done on the appropriate patients. But there are initiatives. There was an initiative brought last year that's coming back again this year to eliminate all prior authorization, essentially, in California, and move to an entire, quote, gold carding system that would enable, essentially, the way it was written last year, it would be 98.5% of all doctors to essentially do whatever they want. And we would have no ability to try to address that on the front end. And when you don't do prior authorization and you do it on the back end, you've got another problem, because now the procedure's already been done. And now you're just talking about payment. So if we start denying payments to hospitals that trusted their doctors to be doing the right thing, they're not going to be happy. And for that matter, the doctors who get denied because they didn't do the right thing, they're not going to be happy. And so if you eliminate both prior authorization and post-service reviews, and you say anything that, that they should be qualified for on the front end, you can't review on the back end, you're essentially taking away any ability to look at providing quality care and to avoid the upcoding issues and the sort of, for want of a better term, unscrupulous behavior of certain individuals. And I understand the burdens of prior authorization, but I also think that it serves a valuable purpose, and that if we do away with that, that it has a great potential to do more harm than good.
Great. Thanks, Bob. So Bill, we've kept you waiting for a while. I'm sorry about that. So we have Bill, and then Joe Skye is next.
So I've built up a number of questions while I was waiting, but just to tag on to the upcoding conversation we just had. Interestingly, in the initial pilot program for PCI, we had a coding as to whether individuals had complex C coronary artery anatomy or not. And that actually determined the risk adjustment for their outcomes. And we looked at it, and typically about 20% of PCIs are what I would call complex anatomy, very calcified or tortuous, et cetera. When we let the individual hospitals and interventionalists code it, we suddenly found there was 45% high complexity lesions, because gamemanship that lowered their risk adjusted mortality when they did that. We got back to we had to individually review every angiogram, contest it, send it back to the hospital. They then appealed and objected, had 4 or 5 people on their side saying it. We had to go to computerized quantitative angiography to prove it before we could make our point that these were not really high risk cases at that time and should be downgraded to the 20% at that time. What I can tell you is it takes an enormous amount of time to contest upgrading. It requires literally one-on-one audits for those cases, and you need even more than that when you go through the appeal process. So the problem with saying or trying to eliminate this upcoding that we see is it's an enormous amount of personnel time and assets that are required to do that. So I don't foresee an easy way around it, no matter what codes that we set for it. The question I had for Dr. Marin and Spertus was, I love the Seattle Angina questionnaire, how it's even more effective than the exercise testing or stress imaging. But how do we get around the fact that in your trial, all individuals initially had CT angios to rule out left main disease. And yes, you only showed about 7% had left main disease. And then you could proceed with that with just the Seattle questionnaire. But does the Seattle questionnaire offer us anything for ruling out left main disease? Or does that mean we have to do a CT coronary angiogram on individuals before we develop or answer that question and use it? And then since for Dr. Scheingold, my question was a Yogi Berra one, and that is, let's say we go to value determined medicine and get away from fee for service. Is there any chance that will get us back to the 11 to 12% GDP that countries like UK and Canada get if we go to the value practiced medicine instead of fee for service? Does that get us back to that 10 or 12% number that other countries have for that? And lastly, for Dr. Plas, for making a decision, yes, it's great to use literature and things like that, but how about using guidelines? One example of that is that we have ACC AHA guidelines for, let's say, coronary calcium that we as clinicians try to follow because we want to practice guideline-based therapy. But yet when we refer that in to the insurance company in this case says, well, even though it's in the guidelines that coronary calcium is appropriate in this select patient group, we still have decided not to reimburse for that. And when we talk to a patient, we say, yes, this is what we recommend. But when they find out there's no reimbursement for it, I would say 80% of those patients say, no, we won't get it done at that point. Is there a possibility that carriers might say or include that, yes, if it's included in guideline-based therapy, we'll follow that, realizing that those guidelines are based on literally 50 or more clinicians and reviews of all the literature at that time? And that's my questions for now, and I'll turn it back to you.
Well, David and go ahead.
I would say this, I'm listening to, Bob's approach for trying to adjudicate overreads of the coronary complexity. And all that comes to my mind is how complicated you are trying to make a very simple question and issue. The question is the patient going to benefit from the treatment or not? And if they have angina, they have a chance to benefit. If they don't, they don't. And making all of these micro dissection of the medical decision making is just fraught with problems, not only the cost of adjudicating and collecting it, but putting the doctor on a tremendous defensive for feeling like he's accused of lying or doing something wrong or making a bad judgment. And to Bill's point, the SAC will not exclude left main disease. David's right. It was my idea to randomize without doing a cath first, which I thought was very important. It was designed to allow the data to be implemented in practice, because if you implement something like Courage, they've already had an angiogram. And by the time they've had the angiogram, the person doing the procedure is going to go ahead and dilate, and you lose that chance. But David didn't say that I advocated very hard for not excluding left main disease patients and just taking all comers. But ultimately, he rightly surveyed our colleagues, and they were unwilling to randomize. Even though the data is based on 150 patients, as he showed, they were unwilling to randomize left main, so we had to do it. But let's keep in mind, Medicare pays $182 for a CT angiogram and $1,800 for a PET or $1,600 for a SPECT scan. So yes, you may have to supplement a $1 Seattle Angio questionnaire with a $180 CTA, but that's not, the status quo is far more expensive than that. And I agree with Steve that, look, eventually if everybody was given a flat budget and said, you've got $10,000 for managing every CAD patient, and I had $10 million to manage the population of patients in my clinic, I can guarantee you the very first thing that we would stop doing would be stress tests. We would be doing aggressive preventive medical therapy. We would be thinking about new coaches to help support the adoption of exercise and a healthy diet. We would address food insecurity. We would provide free statins to our patients. And we would take only those patients with refractory angina that bother them to the cath lab. And the drop in expenses on our side and the profitability we would make would be enormous. But instead, all of our hospital administrators are focused on the top line, not the net profit that they make. The higher they raise the top line, the more they'll get. Even if it's a 1% margin, they're happy to increase the volume. And what we need to do is get to the point where we're not adjudicating how they manage the patient. They're getting a fixed price for that. And they're allowed the freedom and the creativity without the risk of, Stark laws and other, self-interested patient inducement stuff to be able to innovatively treat our patients according to their need and quantifying the value with PROs and survival. And that's it.
Yeah, for the sake of time, I have nothing to add to that beautiful response.
I second that motion with full energy, and give us the, care managers, give us, the promotoras, the social workers, give us the medications that we need, and not jump through so many hoops to get approval for an SGLT2, a GLP-1, and we'll get there.
Thanks.
And so,
I think that,
I'm sorry. Go ahead, Bob.
I think Joe was next, but Bob, if you have a quick comment, then.
Oh, no, go ahead with Joe. I was just trying to address the question from Bill.
Why don't you go ahead and address Bill's question, and then we'll go to Skye.
Okay, and Bill, you had some good questions, and forgive me if I forget a couple, so you may have to jump in and add some more to it. But relative to something that Dr. Spertus was just saying, if it becomes challenging as a health plan to say mandate coronary angiography over invasive coronary angiography. So it's one thing to say that you can get the same data, but we have to have good literature support to show that it is better. Because if they're both equally effective and we can't take cost into consideration, it becomes difficult for us to deny one and mandate the other. It becomes more like we can approve for either one. And so that's one of the problems that we're up against in some of those situations. And now I'm blanking on what your question was for me, Dr. Bonner. What was?
Well, one was just, can we look, we're faced with following guideline practice medicine as far as our responsibility to patients and our potentially legal malpractice responsibility. Could carriers consider adopting well-researched practice guidelines in their coverage?
And the short answer is yes, we can consider it, but here's the problem. Guidelines are not written for operational use. And so when I look at NCCN guidelines, for example, related to cancer drugs and imaging and things like that, they often use terms like may or consider. And that's not helpful when you're trying to make a decision on a review. And the other problem is that oftentimes guidelines, like you said, are created by a group of 40 or 50 doctors, and they wind up compromising. And so it's not always, it becomes, again, a discussion of what the literature entails. And so we do try to incorporate guidelines. We almost universally follow NCCN guidelines, but there are times when we differ from it. And relative to ACC guidelines, we cite ACC guidelines in our medical policies. I'm in the process of reading one of the most recent versions of that and looking at to see if there's other things that we should incorporate. So there's absolutely a value, but it's problematic when we substitute those guidelines for our medical policies. And I'll give you a little bit of an off-base example, but we have a law now in California relative to behavioral health that was passed last year that says that we have to follow nonprofit professional society guidelines, and that our policies can be no more restrictive than those guidelines. Well, one of the issues that we're up against is for gender affirmation surgery. We have to follow WPATH guidelines. Those guidelines were not meant to be followed as utilization management. And they don't address, for example, any sort of cosmetic procedures that are associated with it. None. They don't address them at all. And so how are we supposed to follow a guideline that doesn't even address the issue at hand? So that's part of the problem we get into, is that we definitely try to pay attention to those guidelines. We try to follow them, but there's a big difference between following them and utilizing them in place of our policies, because a lot of times they just don't address some of the issues at hand.
Great. And Joe, have we addressed your question?
No, I will throw out a question here that will combine baseball and then the topics of discussion today. When we look at individual cases, it's often the fact that I will get a case wrong. I will predict that somebody will do well with prevention or maybe lifestyle and dietary management for their angina, and next thing I know, a month later, they're opting to get a stent because we've failed. And patients that I would have pegged for needing to have a cabbage will surprise me and do very well with preventive therapies and weight loss and cardiac rehab and such. My question is this: when we look at value-added reimbursement, has there been any attempts to make the equivalent of a batting average for physicians, where rather than looking at our individual cases, we look at patterns and whether or not we are qualified to get it right most of the time, and therefore be reimbursed even when we get it wrong? In other words, some sort of scale as to whether or not on the average we're getting patients in the right direction at the most cost-effective methodologies.
I'm sorry, who wants to take a swing at that?
Yeah, well, I think, the thing about batting averages is it's one of the few places you can fail 2 out of 3 times and be considered a star, right? If you're batting 333, I think there's probably mechanisms that like accountable care organizations, managed care organizations talk about in data and feedback loops. I don't know exactly what form that data would be fed back, or whether someone would actually calculate. It might be very difficult to do, but I do see the value in providers getting the data on their patients, and not only in what they did for the patient, but months and months of data afterwards. I think one of the things that was found early in providing feedback to physicians is they were surprised just how many other physicians their patients were seeing. So any physician can follow medical record for their patient when they come in to see them, but not necessarily have the information from all the other physicians that a patient might see. Now, in the kind of really integrated delivery systems we might think of, you would hope that everybody in the system has access to the same medical records, and then do with the data, whatever is most valuable for assessing your practice.
David, you've had your hand up, and we're going to give you the last word because we're just about out of time.
Well, I was just going to ask Dr. Sky, what outcome are you looking at? How do you judge success? When you say you got it right, you sort of implied, well, you were able to withhold revascularization and the patient did okay? Is it based on patient's satisfaction, their quality of life, their avoidance of an MI, or just surviving? Or is it the application of guideline-directed medical therapy? I mean, how do you judge when you get it
Yeah.
right versus wrong?
Well, after today, we won't be using stress tests to judge whether we got it right. So no, that's a great question. And I had the same thought. Is I think anecdotally, I think of the patients that I pick up that on average we're having an intervention every 6 months to a couple of years. And with aggressive lifestyle and dietary modifications, you know, they go several years without a stent. And they remain on medical therapy only. I would consider that a success. But my question for the payers is, maybe that costs just as much as having put a stent in every couple of years. That's kind of why I'm looking at these averages and the patterns as to find out what really is value added, because I'm not sure I know every time.
I'm sorry,
No, I
Hattie,
mean-
we're just about out of time. So it's about 2:30. Do you want to give us a few final words?
If people want to keep talking, because people are meeting each other, some for the first time, I'm happy to keep this line open as long as you all want to talk to each other. But I do think we should take a moment to hear from our chairman about what he would like to conclude with.
So number one, I want to thank all of the participants, both on Zoom as well as our speakers today, because I think this is a tremendously important topic for addressing in California. And I think we've brought the very best to bear on this question today. So we want to thank all of our speakers for doing an excellent job in presenting the information that is there. And I think this will give us all impetus for making decisions as we could go forward. Those of us who are clinicians, I think this is very helpful in formulating our ideas about our individual patients and providing them with the absolute best care. And I think it also has implications for both the for the healthcare systems that provide this support, as well as the carriers and as well as the federal government as to decisions they need to make as we go forward for this. So in that this is almost the Ides of March, I wanted to thank everyone for participating today. And we look forward to more exciting programs in the future. We have one at the end of this month, which is going to actually look at or dwell on coronary artery calcium screening and scanning in those individuals. And I think that this is all a great preparation for that. And thank all of our sponsors for Right Care for bringing, allowing us to bring this format to California and to the nation at this point in time. It's incredibly important, and I want to thank everyone for participating, as well as our staff who work diligently behind the scenes to get all the slides up and get everyone connected on Zoom. So on behalf of the Right Care Initiative and all of the speakers today, thank you everyone for a great presentation. And with that, I will sign off because I have a patient call on my other line coming in of someone who's in an ER right now, and I have to unfortunately beg out for that. So thank you, everyone, and have a great afternoon. I think Hattie would keep this open if there's further comments. Thank you.
Thank
I
you,
want to
Bill.
say one thing,
Thanks, everyone.
especially to Steve Scheingold, and that is that I am so glad that his heart surgeon was was so capable and that he's able to be with us today. And I want to say thank you to the amazing surgeons. I mean, for people who need them, like my father who had a quadruple bypass when he was in his early 60s. He got a good 20 years of life after that. That were very impressive years. And so we don't want people to come away from this program thinking that surgery isn't useful. It's very useful, but with the caveat that our wonderful presenters made today. Steve, did you want to say
Bob,
something?
I just wanted to say I'd be remiss if I need to give a shout out to UCSF. When we created our policies, Dr. Rita Redberg was very instrumental in helping us to come up with our criteria. And they recently reached out to us to suggest some further refinements to the policies. And that's some of what is reflected in the slides that I gave. And so I wanted to give a shout out to them for, thanks for that. And to let anybody else know if you have any suggestions, you want to look at our policies and have suggestions for further changes and how we can make them better, then we're always open to that.
Thank you, Dr. Plass. As a UCSF preventive cardiologist, I am grateful for you saying that, and I'm open to reviewing the policies and helping advance this for all Californians in the nation too. Thank you.
Thank you.
Thanks, everybody. Really amazing program. I'm so glad that we're able to introduce you all and benefit from each other's work. Thank you, Steve. Enjoy your time in the Carolinas there. And
I will. Thank you.
Thanks.
Appreciate all of you. Bye now.
Well done. Bye.
Do you want to stay on? Eveline.
Yeah, I have a question for you, Hattie, but we should let everybody sign off.
Oh, there's still 14
People.
people on, and here's Jean rejoining. So it's not a private conversation at all. But
I'll call you.
Okay, good. Okay.
Thank you, Hattie.
Let's take a 5-minute break, everybody.
That was amazing. And thank you for having this open. Bye, everyone.
With us to help make sense of it all.